Diseases of Ear, Nose and Throat and Head and Neck Surgery by P L Dhingra. Chapter 94, Tonsillectomy. Indications of tonsillectomy. They are divided into absolute indications and relative indications. Absolute indications are 1. Recurrent infections of throat. This is the most common indication. Recurrent infections are further defined as A. 7 or more episodes in 1 year, or B. 5 episodes per year for 2 years, or C. 3 episodes per year for 3 years, or D. 2 weeks or more of lost school or work in 1 year. 2. Peritonsillar abscess. In children, tonsillectomy is done 4 to 6 weeks after abscess has been treated. In adults, second attack of peritonsillar abscess forms the absolute indication. 3. Tonsillitis, which causes febrile seizures. 4. Hypertrophy of tonsils causing A. Airway obstruction, sleep apnea, B. Difficulty in deglutition or swallowing, and C. Interference with speech. 5. Suspicion of malignancy. A unilaterally enlarged tonsil may be a lymphoma in children and an epidermoid carcinoma in adults. An excisional biopsy is done. Relative indications. 1. Diphtheria carriers who do not respond to antibiotics. 2. Streptococcal carriers who may be the source of infection to others. 3. Chronic tonsillitis with bad taste or halitosis or bad breath, which is unresponsive to medical treatment. 4. Recurrent streptococcal tonsillitis in a patient with valvular heart disease. C. As a part of another operation. 1. Palatopharyngeoplasty, which is done for sleep apnea syndrome. 2. Glossopharyngeal neurectomy. Tonsil is removed first and then ninth nerve is severed in the bed of tonsil. 3. Removal of styloid process. Contraindications. 1. Hemoglobin level less than 10 gram percentage. 2. Presence of acute infection in upper respiratory tract, even acute tonsillitis. Bleeding is more in the presence of acute infection. 3. Children under 3 years of age. They are poor surgical risks. 4. Overt or submucous cleft palate. 5. Von Willebrand's disease. Bleeding disorders. Example, leukemia, purpura, aplastic anemia, hemophilia, or sickle cell disease. 6. At the time of epidemic of polio. 7. Uncontrolled systemic disease. Example, diabetes, cardiac disease, hypertension, or asthma. 8. Tonsillectomy is avoided during the period of menses. Anesthesia. Usually done under general anesthesia with endotracheal intubation. In adults, it may be done under local anesthesia. Position. Rose's position. That is, patient lies supine with head extended by placing a pillow under the shoulders. A rubber ring is placed under the head to stabilize it. Hyperextension should always be avoided. Steps of operation. Dissection and snare method. 1. Boyles-Davis mouth gag is introduced and opened. It is held in place by Draffin's bipod or a string over a pulley. 2. Tonsil is grasped with tonsil holding forceps and pulled medially. 3. Incision is made in the mucous membrane where it reflects from the tonsil to anterior pillar. It may be extended along the upper pole to mucous membrane between the tonsil and posterior pillar. 4. A blunt curved scissors may be used to dissect the tonsil from the peritonsillar tissue and separate its upper pole. 5. Now the tonsil is held at its upper pole and traction is applied downwards and medially. Dissection is continued with tonsillar dissector or scissors until the lower pole is reached. 6. Now, wire loop of tonsillar snare is threaded over the tonsil onto its pedicle, tightened and the pedicle cut and the tonsil removed. 7. A gauze sponge is placed in the fossa and pressure applied for a few minutes. 8. Bleeding points are tied with silk. Procedure is repeated on the other side. Rose's position for tonsillectomy. Neck is extended by a sandbag under the shoulders and the head is supported on a ring. Tonsillectomy position. Note Draffin's bipod holding Boyles-Davis mouth gag. Set of instruments for tonsillectomy. 1. Knife in kidney tray. 2 and 3. Tooth and non-tooth Vox forceps. Tooth and non-tooth Vox forceps. 4. Tonsil holding forceps. 4. Tonsil holding forceps. 5. Tonsil dissector and anterior pillar retractor. Tonsillar dissector and anterior pillar retractor. 6. Luke's forceps. 7. Scissors. 8. Curved artery forceps. 9. Nugus artery forceps. 10. Tonsillar snare. 11. Boyles-Davis mouth gag with 3 sizes of tongue blades. 12. Doyne's mouth gag. 13. Adenoid curate. 14. Tonsil swabs. 15. Nasopharyngeal pack. 16. Towel clips. A. Tonsil being dissected from its bed. B. The pedicle at the lower pole of tonsil being cut with a snare. Post-operative care. 1. Immediate general care. A. Keep the patient in coma position until full recovery from anesthesia. B. Keep a watch on bleeding from the nose and mouth. C. Keep check on vital signs. Example, pulse rate, respiratory rate and blood pressure. 2. Diet. When patient is fully recovered, he is permitted to take liquids. Example, cold milk or ice cream. Sucking of ice cubes gives relief from pain. Diet is gradually built from soft to solid food. They may take custard, jelly, soft boiled eggs or slice of bread soaked in milk on the second day. Plenty of fluids should be encouraged. Oral hygiene. Patient is given caudies or salt water gargles 3 to 4 times a day. A mouthwash with plain water after every feed helps to keep the mouth clean. Analgesics. Pain locally in the throat and referred to the ear can be relieved by analgesics like paracetamol. An analgesic can be given half an hour before meals. Avoid aspirin and ibuprofen as it can cause bleeding due to decrease in platelet adhesiveness. 5. Antibiotics. A suitable antibiotic can be given orally or injection for a week. Patient is usually sent home 24 hours after operation unless there is some complication. Patient can resume his normal duties within 2 weeks. Other methods for tonsillectomy. 1. Guillotine method. Largely abandoned. It can be done only when the tonsils are mobile and tonsil bed has not been scarred by repeated infection. 2. Electrocautery. Both unipolar and bipolar electrocautery has been used. It reduces blood loss but causes thermal injury to tissues. 3. Laser tonsillectomy. It is indicated in coagulation disorders. Both KTP 512 and CO2 lasers have been used, but the former is preferred. The technique is similar to the ones used in dissection method. 4. Laser tonsillotomy. Another method is laser tonsillectomy, which aims to reduce the size of tonsils. It is indicated in patients who are unable to tolerate general anesthesia. Tonsils are reduced by laser ablation up to the anterior pillars in stages by repeated applications. 5. Intracapsular tonsillectomy. With the use of powered instruments, debrider, tonsil is removed, but its capsule is preserved in the hope to reduce post-operative pain. 6. Harmonic scalpel. It uses ultrasound to cut and coagulate tissues. It is a cold method and causes less tissue damage and less post-operative pain compared to electrocautery technique. 7. Plasma-mediated ablation or tonsillectomy technique. In this ablation method, protons are energized to break the molecular bonds between tissues. It is a cold method and does not cause thermal injury. Cryosurgical technique. Tonsil is frozen by application of cryoprobe and then allowed to thaw. 2 applications, each of 3 to 4 minutes, are applied. Tonsillar tissue will undergo necrosis and later fall off, leaving a granulating surface. Bleeding is less due to thrombosis of vessels caused by freezing. 9. Coblation tonsillectomy. Techniques of tonsillectomy or tonsillotomy. Cold methods and hot methods. Cold methods, dissection and snare, most common. Guillotine method, intracapsular capsule preserving tonsillectomy with debrider. Harmonic scalpel, ultrasound. Plasma mediated ablation or dissection technique, coblation. Cryosurgical techniques. Hot methods, electrocautery, laser tonsillectomy or tonsillotomy, CO2 or KTP, radiofrequency. Tonsillectomy with coblation. Complications. A. Immediate complications. 1. Primary hemorrhage occurs at the time of operation. It can be controlled by pressure, ligation, or electrocoagulation of the bleeding vessels. 2. Reactionary hemorrhage occurs within a period of 24 hours and can be controlled by simple measures such as removal of the clot, application of pressure, or vasoconstrictor. The presence of a clot prevents the clipping action of the superior constrictor muscle on the vessel which pass through it. Compare postpartum uterine bleeding. If above measures fail, ligation or electrocoagulation of the bleeding vessel can be done under general anesthesia. 3. Injury to tonsillar pillars, uvula, soft palate, tongue, or superior constrictor muscle due to bad surgical technique. 4. Injury to teeth. 5. Aspiration of blood. 6. Facial edema. Some patients get edema of the face, particularly of the eyelids. 7. Surgical emphysema. Rarely occurs due to injury to superior constrictor muscle. Mortality rate of 1 is to 35,000 has been reported. Delayed complications. 1. Secondary hemorrhage. Usually seen between the 5th to 10th post-operative days. It is the result of sepsis and premature separation of the membrane. Usually it is heralded by blood-stained sputum but may be profuse. A case of secondary hemorrhage, the patient should be admitted to the hospital. If it is only a clot in the fossa, patient is observed. It may disappear of its own or with dilute hydrogen peroxide gargles. If there is active bleeding, patient is taken to the operation theatre and hemostasis achieved under general anesthesia. In all cases, the coagulation profile and hematocrit is repeated. In severe cases, the blood or its components may be needed. Some rare cases may require external carotid artery ligation. Infection. Infection of tonsillar fossa may lead to parapharyngeal abscess or otitis media. 3. Lung complications. Aspiration of blood, mucus or tissue fragments may cause atelectasis or lung abscess. 4. Scarring in soft palate and pillars. 5. Tonsillar remnants, tonsil tags or tissues left due to inadequate surgery may get repeatedly infected. 6. Hypertrophy of lingual tonsils. There is a late complication and is compensatory to the loss of palatine tonsil. Sometimes lymphoid tissues left in the plica triangularis near the lower pole of tonsil, which later gets hypertrophied. Plica triangularis should therefore be removed during tonsillectomy. Thank you.